Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you for being with me again and giving me another chance to speak and to share with all of you about the integration of HIV services into primary health care in Malaysia. Okay, a little bit on the country context. Malaysia is a Southeast Asian country with a diverse population of approximately 32 million people comprising of various ethnic and religious groups. Although Islam is the official religion of the country, but there are also significant numbers, a proportion of those who profess Buddhism, Hinduism, Christian, and so on and so forth. And it is important to note that the country operates a dual healthcare system under a federal structure. So this is a plus point. I would say that it is directive from up and go down, so to ensure that the health service delivery is standardized throughout the states or province. I mean, in Pakistan you call it province, but in Malaysia we call it states. We have 14 states altogether. So it is under the purview of the federal government. And at the same, what is important is that those under federal structure are heavily subsidized and widespread access. In terms of healthcare, Malaysia uses a mix of government-funded public services and private healthcare that people pay directly or through insurance scheme. Malaysia has a strong primary healthcare system that focuses on community-based care. There are over 2,800 public clinics or static public clinics and close to 8,000 private clinics throughout the country. And okay, this is the evolution of primary healthcare services in Malaysia. Since the Alma-Ata Declaration, Malaysia has transformed its primary healthcare services to meet the changing health needs of the population. Now, our services have expanded from the very basic maternal and child health back then in 1960s to include a comprehensive range of services like dental care, mental health, communicable diseases, and now the specialized treatment for HIV, and later included hepatitis C and B. The integration of HIV services into primary care began earnestly in 2003 with the focus of making affordable drugs available under the compulsory licensing using a treat flexibility. Hepatitis C treatments followed in 2018, just recently, not so long ago. We implemented a more comprehensive approach for all communicable diseases, reflecting our commitment to health system. The ongoing evolution reflects Malaysia's commitment to accessible and comprehensive healthcare for all citizens. So it makes the treatment of HIV and co-infections much easier because you don't have to refer them. You know, when a patient comes to any health center, they get screened for HIV, for example, and then diagnosed as HIV, automatically they will be, he or she will be screened for other diseases like STI, hepatitis C, hepatitis B, and if found to be positive, they will be treated together under the same roof, which is the primary healthcare integration concept in Malaysia. Okay, now in tandem with the evolution of physical restructuring and reorganization of primary healthcare services to meet the changing population needs, Malaysia has also invested heavily in strengthening the health workforce. And our primary healthcare teams are multidisciplinary, comprising of doctors, allied health like nurses, and then we have also assistant medical officers, and we have dentists, pharmacists, radiographers, lab technologists, and family medicine specialists placed, and that is actually the workforce of each and every health centers which is under the government, under the Ministry of Health. And this diverse team ensures that all aspects of health are addressed, making our healthcare system robust and resilient. Okay, now let me share the insights of the innovative integration of HIV care, linking the community-led services into the primary care system in Malaysia. Now, we call this model GO, NGO, or government, non-government, so we normally call it GONGO. All right, so this is a model in Malaysia that we call GONGO model that exemplifies how collaborative efforts between the government and NGO, catalyzed by a working policy or a practical policy changes, can effectively lead to seamless HIV care. In Malaysia, the government has implemented a unique policy on social contracting that has been a cornerstone of our approach to HIV integration since the 1990s. So there is a policy where government can fund NGO. Which type of NGO? Any NGO that complement the government objective, not limiting to HIV only. So even have an NGO who run dialysis center for renal impairment, so they get funded by the government as well to buy a dialysis machine with condition that those who goes for the dialysis will be charged minimal, all right? So this is a concept that has been in place since 1990s. And this policy allows non-government to receive special fund. And for HIV, which was formed in 1992, since then, the government has allocated significant amount. To date, I think Malaysian Health Council has received at least 185 million ringgit Malaysia from 1992 to 2023, right? That's quite a huge amount. Roughly now that Malaysian Health Council has been allocated about 7 million ringgit Malaysia every year to run the HIV program. Through these annual allocations and target agreements, there is a contract, of course. When we give, the government give 7 million, there will be a contract that they promise that they will provide this kind of service and will achieve this KPI or targets. So these all are documented and legalized, right? Okay, so significant policy changes also have been instrumental in integrating community-led services within our primary care framework. Malaysia introduced a model that which we call KK model. KK is in local language, means health center model, right? Allowing NGOs to work from within the primary care spaces without payment. So we have a government clinic, health centers. We also have an NGO placed and working from within the primary care clinics, which belongs to the government. This not only bringing or bridging the community to the healthcare provider, but at the same time eliminating or erasing stigma and discrimination between both, against among the healthcare providers against the key population and so on and so forth. Okay, so this KK model not only facilitate bringing in the client to healthcare providers, provided the services provided by the government, but it is also foster collaboration between community health workers and the primary care providers, right? Notably in areas like methadone clinic, HIV clinic, STI services, and hepatitis C as well. And the new one, is pre-exposure prophylaxis services. Unified monitoring and evaluation, which is MNE system, further strengthen the integration of NGOs into the primary care system, ensuring accountability and effectiveness. It is not just about the government allocate 7 million and that's it. No, they are binded by a contract that they must achieve. So every 6 months they will be assessed. We will have dialogue. They will present their achievement. So if they are not achieving, so we give them allocation another 3 months to make sure they can keep up with what they promised to achieve. But if they fail, we're going to cut the budget. This is how we work with the NGO, right? So the NGOs will always have to be on their foot to make sure that they achieve the target that has been set together between the NGO as well as the government. Okay. Building on our discussion of how Malaysia integrates community-led services into primary care, this slide delves into the sustainability of those services through different phases. So I summarize it into 1, 2, 3, 4, 5 phases. We can see it started with foundation phase. Initially, HIV services in Malaysia were very fragmented across various NGOs, offering specific interventions like needle and exchange program by one NGO that capitalized or specialized only in PWID, for example, and MSM-based organization only providing services to MSM population only. And we end up within one geographical area, you have multiple NGO, and it is not cost effective. So what we decided within this differentiated approach, we want an NGO, only one NGO in certain location, but the NGO will provide to all key population. So we uplift their role, right? So we increase the allowance, right? So that they cover all 4. So there is no duplication. Because you know that, it is one-stop center. We want an NGO where they go out for outreach. They meet people who inject drugs. They meet MSM. They meet transgender population, even sex workers. They should be able to provide the services rather than referring to another NGO for female sex workers, for example, or for MSM they refer for another NGO, but it is within the same geography. So this is at the beginning, which is foundation phase. What we see is that we are not able to expand within the same amount of budget that the government has allocated, which is 7 million, which has not increased, but touch wood, it never reduced. Okay. Now the next phase is enhancement phase. The program evolved to expand service coverage and integrate these services within the primary care system using the health clinic model, which is the KK model, improving the testing and case management with support from the Global Fund. And so on, moving on the consolidation phase. Services were streamlined across HIV care continuum, ensuring that all key populations could access comprehensive services through a unified system that included data management as well and clinic integration. And we went to rollout phase. The integrated services were expanded nationally with significant steps like certifying community health workers as tester. So we accredit them. They have to undergo a series of training and then attachment with health clinics under the supervisions of allied health of doctors, and then we certify them as certified tester by the government, by the Ministry of Health. So this is the level that we acknowledge or we accredit the community health workers in terms of providing HIV tests, a quality HIV test. Okay, and lastly, sustainability phase. The health clinic model, or the KK model, was adopted as a national program, absorbing the NGO operational costs and incorporating methadone maintenance and PrEP into primary care. And this phase also focuses on reducing stigma and securing ongoing support from private funding, including a tripartite model, which is recently introduced, bringing in the corporate body to fund the projects, specific project in certain area. And this would, hope that the program would sustain and enhance the initiative, even without global funding. So I think that ends my presentation. Thank you for your attention.